We can put up the slide. Thank you, and good morning, everyone. I'm Tomoyuki Mizuno, and I appreciate the opportunity to introduce our new exciting project. So before starting, I'd like to thank NICHD and Endpoint Hub for their funding support on this project. And in this project, we aim to develop a physiology-based pharmacokinetic model for buprenorphine in pregnant women and their fetuses to predict in utero drug exposure during pregnancy. And in addition, we will investigate the buprenorphine pharmacogenetics in neonates with neonatal opioid withdrawal syndrome, also called NAWS. Next slide, please. So here is a brief background of the project. And as mentioned by Dr. Patrick yesterday, the opioid epidemic has been a huge public problem in the United States. And according to CDC, more than 130 people die after overdosing on opioids every day. So this opioid epidemic significantly impacts babies who are born to mothers taking opioids during pregnancy. And such babies frequently suffer opioid withdrawal syndrome as a result of chronic in utero opioid exposure. So NAWS is associated with severe neonatal and childhood morbidities and prolonged hospitalization. Therefore, providing adequate treatment is very important to save these babies and their parents. However, widely accepted standard medications are still under establishment. Next slide, please. Okay, so buprenorphine is an emerging pharmacological treatment of NAWS, and several recent studies indicate that buprenorphine could provide better outcomes than conventional opioids such as morphine and methadone. However, the optimal and individualized dosing strategy has not been established. So there is large variability in buprenorphine PK/PD in neonates. However, there are very limited data on factors predictive of buprenorphine PK/PD in this population, including pharmacogenetics. Also, buprenorphine is one of the most used drugs for opioid use disorder during pregnancy. And some previous studies suggest that the degree of in utero opioid exposure may be associated with the severity of NAWS after birth. However, it is still unclear how the buprenorphine exposure during pregnancy is associated with postnatal NAWS severity due to the lack of technology to precisely determine the in utero exposure. Next slide, please. So recently, we developed a physiology-based pharmacokinetic model for buprenorphine in neonates. And the PBPK model is a mathematical modeling technique to describe drug disposition using drug physicochemical properties and patient physiology. And as I also mentioned several times yesterday, recently, significant advancement was made in applying this approach to construct a maternal fetal PBPK model to predict drug disposition in pregnant women and their unborn babies. Next slide, please. So by using this approach, the first goal of this project is to develop a maternal fetal PBPK model to predict in utero uterine exposure to buprenorphine during pregnancy. And the estimated in utero exposure will be used to investigate its effect on the postnatal NAWS severity. Second goal is to investigate buprenorphine pharmacogenetics in neonates. And the clinical data will be collected as part of our ongoing prospective pilot study. And we expect that this project will generate preliminary data on the candidate genetic variants, and the results will inform a study design for a larger study to confirm the findings in this pilot project. In addition, so we will also use this identified pharmacogenetics information to improve our neonatal PBPK model prediction in each subpopulation to explore the potential benefit of pharmacogenetics guided dosing. So our overarching goal is to develop model-informed population dosing strategy to investigate the prediction of NAWS severity and pharmacogenetics in neonates. Next slide, please. So lastly, I'd like to thank my co-investigators and collaborators for this project. And again, I'd like to thank NICHD and Endpoint Hub for their financial support on this project. with that, thank you for your kind attention. And I am looking forward to sharing some good results with you soon. Thank you.
Great. Thank you, Tomiyuko. I think we'll save questions for the end for our speakers. We'll go ahead and move to our next speaker, Dr. Kara Rood. Kara?
Hi, good morning. Thank you so much for the opportunity to speak on our project. It's a collaboration between Ohio State and UTMB, and our focus was using exosomes as a pharmacodynamic endpoint to determine aspirin dosing for the prevention of preeclampsia, and this is a pilot proof of concept study. So preeclampsia occurs in about 5 to 8% of pregnancies, and it's associated with significant maternal and neonatal morbidity and mortality. To date, the United States Preventative Task Force, ACOG, and SMFM all recommend the dose or the use of low-dose aspirin for preeclampsia prevention in pregnant individuals at high risk for developing this disease. There's mixed literature on what the optimal dose may be. We currently use 81 milligrams daily. However, there is literature based on many different systematic reviews that says greater than 100 milligrams daily may actually improve outcomes. So given this controversy and a recent advancement in isolating specific extracellular vesicles known as exosomes from maternal blood and characterizing their cargo content, which have helped to better understand the response to therapeutic interventions, because exosomes reflect the state of a cell at the time of the release, providing like a physiologic snapshot of the cells. And although diagnostic potential of exosomes have been reported, there really has been no studies that have examined the response to therapeutic interventions, such as different doses of aspirin on these exosomes. And what we do know is that aspirin does affect endothelial and trophoblast cells, thus potentially modulating the exosome derived from these cells through either quantity and characteristics as well as their cargo contents. So therefore, we propose this proof of concept study that looks at exosome profiling that's going to look at the response to the different doses of aspirin therapy in patients at high risk for developing preeclampsia. In order to facilitate this, we are leveraging a biobank of previously collected biological maternal samples from 40 high-risk patients who were assigned to either 81 or 162 milligrams of aspirin, and also using a cohort of gestational age matched low-risk patients without preeclampsia or other adverse pregnancy outcomes and that are not on aspirin. Next slide. So we will be testing these specific aims. Primary aim 1 is characterize the maternal plasma and the proteome profile in high-risk individuals receiving the different doses of aspirin, either 81 or 162. And our hope is to demonstrate that the proteome profile from patients receiving a higher dose of aspirin is more likely to mimic what we see in our low-risk control groups when compared to the profile of patients who received the lower dose, the 81 milligrams of aspirin. And then our second aim is to compare some of the angiogenic and inflammatory biomarkers in these high-risk individuals on the different doses of aspirin and whether these biomarkers correlate with the changes in the maternal exosome proteome profile, as well as the clinical outcomes such as the development of preeclampsia. Next one. Our overarching hypothesis is that exosomes can be used as biomarkers and serve as pharmacodynamic endpoints in assessing response to different doses of aspirin in patients that are at high risk for developing preeclampsia. And for our study design, we are currently conducting a randomized control trial of so far over 100 high-risk patients that have been assigned to either 81 or 162. So we're using these samples here as well as matched gestational age controls for our analysis. And our primary outcome on the next slide is maternal plasma exosome proteome profile for individuals on the different doses. And our secondary aim would be some of our soluble fluid PLGF, IL-6 concentrations, as well as clinical outcomes such as preeclampsia, preterm birth, the severity of preeclampsia, fetal growth restriction, and some short-term neonatal outcomes. Next slide. So currently we have the IRB updated and approved. The material transfer agreement and contract is in place with UTMB. All of our samples have been collected and are shipped there. There's established protocols in place. There's some additional hiring of personnel for analysis. And then we are now working on obtaining preliminary data so that we could hopefully apply for future large funding opportunities and evaluate further the role of these exosomes in different aspirin dosings and preeclampsia prevention. Thank you very much again for this opportunity and for the NICHD and MPrint Hub for the funding.
Yep. All right, great. Thank you, Kara. Now, Miranda Kiefer was on clinical duty today, so
Hello, good morning. My name is Miranda Kiefer. I'm one of the maternal fetal medicine fellows at The Ohio State University. I'm one of the 2022 Imprint Opportunity Pool awardees, and my project is titled Frequency and Dosing of Nifedipine in Women with Severe Preeclampsia Undergoing Expectant Management.
Yeah.
Expectant management of severe preeclampsia until 34 weeks remains the mainstay of treatment, and optimizing blood pressures with long-acting agents reduces the risk of emergent delivery. One of the most commonly used blood pressure medications for this purpose is Nifedipine XL. However, there is variation in dosing and limited data on the pharmacokinetics and optimal dosing of nifedipine in pregnancy exists. In the non-pregnant individual, the XL formulation delivers the drug at a constant rate for 16 to 18 hours. However, this rate may be interrupted or shortened due to physiologic changes of pregnancy, which include delayed gastric emptying, increased volume of distribution, and increased renal elimination. We had two aims for the study. The primary aim is to compare the rates of suboptimal blood pressure control in pregnant women undergoing expectant management for preeclampsia with severe features when initiated on nifedipine 60 milligrams XL once daily versus nifedipine 30 milligrams XL twice daily. The secondary aim, which is the MPrint funded opportunity, is to assess the mean plasma concentration levels of nifedipine XL when dosed daily or BID serially over a 24-hour period. Our hypothesis is that among women with preeclampsia with severe features undergoing expectant management, nifedipine 30 milligrams XL twice daily improves blood pressure control when compared to nifedipine 60 milligrams XL once daily. Our study design is an unblinded randomized controlled trial in patients admitted for expectant management for preeclampsia with severe features. Patients will be enrolled when the decision is made to increase the daily dose of nifedipine XL from 30 milligrams to 60 milligrams, and they will be randomized into one of two groups, either once daily nifedipine XL 60 milligrams or twice daily nifedipine XL 30 milligrams. The co-primary outcomes for the primary aim is the frequency of suboptimal blood pressure. We will compare the mean number of suboptimal blood pressure events between groups. And for the secondary aim is the mean plasma levels of the nifedipine within participants who are co-enrolled when measured at T equals 0, 1, 2, 4, 6, 12, and 24 hours after the administration of the randomized dose. Currently, we have screened 25 participants who have been admitted with severe preeclampsia prior to 34 weeks. We have consented 21 participants who are initiated on nifedipine 30 milligrams XL. And of those, we have enrolled 14 participants, as they can only be enrolled when they are increased from 30 milligrams to a 60 milligram daily dose. Our goal enrollment is 56 participants. For the secondary aim, we have co-enrolled 6 participants, and due to resource availability, the goal enrollment for the pharmacokinetic study is 20 participants. So we are well on our way to enrolling and collecting data on our participants. We're very excited to analyze the data. And that's all I have for you this morning. Thank you. Hello.
All right,